the essential classification, the essential classification remains the same. So we have the primary headache disorders, then we have the secondary headache disorders, and then we have painful cranial neuropathies and other facial pain. So the primary headache disorders are the base four, that is migraine, tension type headache, trigeminal autonomic cephalgias, and the other much less common primary headache disorders. And I think among these, probably trigeminal autonomic cephalgias is something that would they probably would primarily first present to an ophthalmologist because of the peculiar symptom complex that we encountered in this particular type of headache semiology. So, what we need to understand is that there are pain sensitive structures both extracranially and intracranially, and when these extracranial when any of these pain structures are involved due to local infiltration or due to any local infection, then what we encounter is a secondary headache disorder. While in primary headache disorder, obviously there is no structural pathology involved, which is why by definition it is primary. um so we will begin with migraine headache. So in general, the sensory the distributions of headache may be similar, but headache do feel each migrainer has a different experience with headache per se. So this diagram basically illustrates the classical pattern of distribution of various types of headaches. And when it comes to migraine by classically is usually hemicranial alternating, but hemicranial in nature. So migraine is actually derived from the Greek word hemicranos, which means half head, and this underscores the unilateral distribution of headache. So it is a complex disabling neurovascular disorder. There is recurrent episodes of headache. There are visual sensory symptoms which is basically known as an aura, that arise more often than not before the headache, may occur afterwards also. So here we have put, and I've just put an example of what an aura can look like. Now, the 1 year prevalence is 12% in the general population. It afflicts prepubescent boys and girls with a similar frequency, and it manifests with fluctuating frequency of attacks throughout one's life, and typically towards milder and less frequent migraineurs later in life. Lifetime prevalence is 33% in women and 13% in men. Now, this fluctuating frequencies and typical trend towards milder and less frequent. So, this is one of the things we do need to remember, that extremes of age is always a red flag sign in migraine. New onset migraine above the age of 45 is something that is very uncommon, and we do need to make sure we rule out secondary causes there. Now, in India, we don't actually have very precise or very specific population-based studies as such. The age standardized 1 year prevalence is about 25.2%. Prevalence is greater among females, and prevalence is surprisingly greater among the rural area, with a peak age noted between 35 to 45 years. And coming to migraine burden, so it's a disabling disorder. It affects more than 10% of the adults worldwide, and it is among the rank of disabling disorders. It's the sixth most disabling disorder. The essential problem with migraine is that it reduces the functionality and the capacity of a person during those migraine episodes, during the premonitory phase. So this is something that can be very, very burdening to the patient. Now, we classically, all of us know this, that basically when we classify migraine, you have the classic migraine without aura, and then you have the classic migraine with aura. And even then, among patients with aura, we have typical aura, brainstem aura, hemiplegic migraine, retinal migraine. Now, what we need to understand is, essentially, when we have a patient coming with complaints of headache, and they have a typical aura or they may not have a typical aura, patients with aura, we know that they are more predisposed to prothrombotic states also. They have a higher chance of infarction compared to the general population. So whenever patients come with a very typical aura, that should be something in the back of your mind as well. So uh, now, typical migraine with the sorry, uh, when we have migraine without aura, so we have to have now this what this 1, 2, A, B, C, D, and E. This is something that is the IC classification of headache disorders used for all types of migraines. And it essentially says that point A should be at least 5 attacks fulfilling point B to D, wherein each headache should last for 4 to 72 hours, which it has at least one of two characteristics where it is unilateral, pulsating, moderate or severe in intensity, and aggravated by or causing avoidance of routine physical activity. And during the headache, patient has nausea and or vomiting along with photophobia and phonophobia. So at least 5 attacks should be present that fulfills the category from B to D. And E, this is a point that is there in all of the types of headache classification where it is not better accounted for by another ICHD3 diagnosis. So then when it comes to migraine with aura, so here it should be similar to the migraine without aura, but they should have 1 or 2 attacks with 1 or more fully reversible aura symptoms. And here it can be the visual, sensory, speech and language, motor, brainstem, or retinal. And it should have at least 2 of the following 4 characteristics, wherein at least one aura symptom spreads gradually over 5 minutes. Each individual aura symptom lasts for 5 to 16 minutes. At least one aura symptom is unilateral. Aura is accompanied or followed within 60 minutes by headache, and of course not better accounted by any other ICDH3 diagnosis. Here I've just given an example of all the visual disturbances a patient of migraine can present with. And approximately 20 to 30% of migraineurs do suffer from experience aura. So now coming to the pathophysiology. So over the years, there has been a lot of debate as to what is the precise pathophysiology. First, it was only the vascular theory, then it was only the neurological theory, the neuroinflammation theory that was proposed. And there were animal models. Then we came to functional MRI, where we tried to see the areas of the brain that are predominantly affected. But one unifying hypothesis is the involvement of the trigeminocervical system, which is predominantly mediating these pain pathways. So, basically, we don't need to go into the anatomical details, but what happens with the activation of this trigeminocervical system is that there is a sympathetic innervation, which will lead to vasoconstriction. There is parasympathetic fiber activation, and this leads to vasodilation. And we do remember that in migraine, it is not just vasoconstriction or vasodilation, but interlink between the two that causes the symptom complex. And then the sensory innervations, which include substance P, CGRP, and in fact, CGRP is that is calcitonin gene-related peptide, is a recent molecule, a targeted molecule that is being used for recent migraine medications, the newer set of migraine medications. So coming to a summary of the base theory. So the vascular theory says that there's vascular disturbance, vasodilation, vasoconstriction, inflammation, and involvement of the serotonergic system. And this is why the ergot alkaloids and all were used for immediate abortive medications. Then the neural theory, which basically is a hyper excitability in the form of a cortical spreading depolarization. And then there were alternative theories that may overlap with key mechanisms that basically causes neural inflammation leading to migraine pain. So basically, the current understanding is that it's a neurovascular process. This activates blood vessels. This leads to pain, and this leads to further nerve activation. And they say that the threshold in females for cortical spreading depression is lower compared to males, and this may give us a clue as to why migraine predisposition is more in females. So CGRP, again, that goes into a little bit more of details into what is happening, but I think this is a slide that summarizes what's happening. So we have the abnormal neuronal activity, and this leads to the release of neuropeptides. And this neuropeptides include substance P, neurokinin A, calcitonin gene-related polypeptide, and serotonin. Now, what this does is this will promote vasodilation, and this will lead to plasma protein extravasation. And this leads to an inflammatory response, which sensitizes the tissues to the perception of pain and produces headache. This in turn will activate the trigeminovascular system, which in turn stimulates the neurons in the brainstem and the upper spinal cord, and this activates the nociceptive trigeminovascular system, which causes the prolonged pain. And then the cerebral cortex, the thalamus, the hypothalamus, these are also influenced. And that is the other neurocognitive responses that we do see in acute migraine attack. So basically what it says is that there is a cortical spreading depression, which is basically a bioelectrical impulse, a spreading wave. This spreading wave will be preceded will be succeeded by hyperemia. So you have your vasoconstriction, vasodilation. This leads to headache, inflammation, sympathetic activation. Centrally, what you get is the sensory symptoms, and peripherally, what you get is the autonomic symptoms. Coming to migraine genetics. Now, migraine genetics is very complex. It is polygenic. It doesn't follow the Mendelian pattern of autosomal dominance, autosomal recessive, except for the familial hemiplegic migraine. Familial hemiplegic migraine is again very rare. It's a very rare entity where there is hemiparesis, typical migraine, usually with aura, and there is a very, very clear-cut family history, something that it's not a very common thing. But other than that, it's a polygenic and it's a multifactorial inheritance pattern. But usually, more often than not, we do get a strong family history of migraine. And in fact, when in the OPD and when in doubt and they've come with new onset symptoms and there is a strong family history of migraine, this can also be a point that say that, okay, fine, I am probably dealing with a primary headache pathology and not with a secondary headache pathology. Coming to the phases of the migraine, I think I've already mentioned this. So the first phase is basically the premonitory phase, and this phase can last for hours to sometime even days. And the basic mechanism here is involvement of the hypothalamus. And here there is a warning symptom. So a frequent migrainer knows that there is an impending attack that's happening. There can be mood changes, food cravings, yawning, patient saying brain fog, I'm not able to do my work very efficiently. There is disturbed sleep, frequent urination can happen again because this is because of the involvement of the hypothalamic axis, nausea, ache, stiffness, speech disturbances, and language problems. Then comes the aura, which we mentioned 20 to 30% of patients can experience, which can be visual, sensory, retinal, etc. I'm sorry. Okay. So then we come to the acute phase, which is actually the headache, and then the resolution phase, the postdrome, which basically is called a migraine hangover when patient is fatigued, and finally the interictal phase, which is a phase between the two episodes of headache. So the problem, what happens is the days that the migrainer has full functionality is reduced by this whole migraine episode, because a premonitory phase that can last very long and reduce the functionality of a patient is something very debilitating. So now, before I go on to the other primary headaches, I will just wind up first with migraine. So coming to the treatment of migraine.
Can I interrupt you for a while?
Yes, please, ma'am.
Can there be different types
Hello?
of aura in the same patient, like the same individual? Can he experience
Hello?
different? Can you hear me?
Yes, ma'am, I can hear you.
Yeah. Can the same individual experience different
Yes.
types of aura at different episodes,
Yes,
or
ma'am.
is it always the same?
Definitely. No. It's not the same. It's not the same. But usually each person has what do you say, a predisposition to develop a certain type of aura. But for example, a retinal aura will usually have a retinal aura, a brainstem aura. Usually they have a brainstem aura. But the same individual can have a less frequent other type of aura as well.
So this aura, how do we differentiate it in a peripheral setting? If we come across a patient with aura, the way he describes it,
Yes.
how can we differentiate it
Yes.
from a hallucination or something that is organic?
So, ma'am, that is actually a very good question. So the main things that we have to deal with. So usually the differentials in this case, okay, first you want to know whether it's organic or inorganic, because even organic symptoms like even a TIA or a sensory seizure or a aura in migraine. So these are three things that is very important to differentiate. And when it comes to, if you're thinking of a hallucination, whether it's a hallucination like a non-organic issue versus an organic issue. So especially non-organic hallucinations, they're usually vivid, they're usually auditory hallucinations as well. They will not have the background history of migraine, they will not have post-proceeding headache per se. Aura, once a patient has an aura, the description will be classical to that particular sensory system that is activated, and there is always history of succeeding headache. So organic versus inorganic may not be a doubt. What I feel is something more challenging is to make sure we are not mistaking it to and missing out on, say, a sensory seizure, or missing out on, say, a TIA for that matter. So even there, here, the frequency, the background history, and the preceding, or rather, I'm sorry, the succeeding episodes of headache is one that help us clinch the diagnosis.
Thanks, Vimala.
I'm sorry, anything?
Thank you.
Hello?
Thank you. Please continue.
Yeah. Yeah. Now the thing about migraine is it's a lifelong disease, and yes, with age, the symptoms and the magnitude does come down. But very practically speaking, we cannot ensure a cure, and patients do have to live with it. So it does make sense to advise lifestyle changes rather than a very strict pharmacological management. Of course, pharmacological management is a must, and it is what's most important as well. But lifestyle changes are very, very important. Uh, Always explanation, setting realistic objectives. And then when we begin our treatment, we have basically two major things that we have to deal with. That is, one is the treatment of the acute attack per se, and next is the treatment to reduce the attack frequency, or that is our prophylactic medications. So, one important thing in migraineurs is to advise them to maintain a migraine diary. So, what they are asked to do is you maintain a diary saying today you had headache. So, today, what is the other different thing you did? What is the other diet you had? Was there any difference in your sleep pattern? And by doing this, they can identify the triggers. So, identifying of triggers is very specific. Triggers are variable in many patients. In some, it can be cheese, in some, it can be coffee. In fact, in some, it can be lack of coffee as well. So, it is very individualistic, and maintaining a migraine diary will help identify the triggers. Universally, though, aged cheeses and dark chocolates, they are something that usually act as a migraine trigger. Meditation, relaxation training, cognitive behavioral training are also other non-pharmacological treatments that can be followed. Again, this is something I already spoke of. Diet is something very, very important. Many patients do come and say that, after I had this, and I've had severe attacks, and sometimes there's basically nothing else we can do other than avoidance of that particular dietary trigger. Behavioral therapy. So here we have a simple things like biofeedback. So here, something that is not very commonly done, I suppose, around India, but in this, what we do is that the patient will be connected to certain biofeedback monitors. So that can be an EMG, or that can be an EEG. So basically, what happens is the counselor speaks to the patient, and we see the monitor of what is the patient's vitals, what is the EMG reading showing, what is the muscle activity, and then the patient tries to control the vitals to an extent where the patient knows that all the vitals are now in a non-stress zone. So it is a time consuming process, but it is something that is what do you say, long term sustainable, because it's basically a non pharmacological type of maneuver. Okay. And of course, hydration is must. Migraineurs are frequently dehydrated, and because of the systemic manifestations as well, they have a lot of nausea, vomiting, which is why, in fact, we combine domperidone along with NSAIDs, and ice pack does help, deep breathing helps, guided medication, and biofeedback, etc.
What
Now,
do
for
you
the
mean
purpose of
by
treatment,
sorry, Vimala? What do you mean
yes, ma'am,
by ice pack? How do you use that?
local
Oh,
application.
that's
That's all.
yeah. Okay.
So, for the purpose of treatment consideration, migraine attacks can be classified into three categories. So, one is the mild migraine, where there is occasional throbbing headache and no major functional impairment. Then is the moderate migraine, where there is moderate or severe headache and some impairment of functioning along with nausea. And severe migraine, where there are more than three attacks in a month with significant functional impairment and marked nausea and vomiting. So, as I said before, we have symptomatic, we have prophylactic, and we have intermittent prophylaxis. Intermittent, this is something I did not actually mention. So, we have something, a catamenial migraine. So, basically, migraine experienced by women only during certain phase of the menstrual cycle. It can be during the follicular phase, so luteal phase, etc. Again, it is variable, and this one is related to hormonal variations. So, in this case, you can actually give intermittent prophylaxis, wherein we try to trace based on the menstrual calendar. This is the particular time the patient is predisposed to develop it, and that time we can give prophylaxis only during that. So, now the classes of migraine are over-the-counter NSAID specific prescription drugs, which are basically triptans and ergoids, and then of course our prophylactic treatment. Now, in general, ergotamines are something I'll come back to that later. So now analgesics, aspirin and acetaminophen have been shown to be effective for the treatment of mild migraine. So is ibuprofen. Naproxen has been approved even in combination with sumatriptan. In my practice, I have found that naproxen in combination with domperidone is a great drug. And always this abortive medications should be initiated as soon as the patient starts to develop that migraine aura and he knows he's going to develop the headache. Because once that peak headache starts, the medications become less effective. So usually we give a combination of 500, if a patient's weight is more than say 50, 60, 500 mg naproxen with domperidone. If not, we can, if the weight is say 40, 45, we can give 250 mg. It's a commonly available drug, which is Naxdom. So that is something that you can safely use for all migraine prophylaxis. Of course, NSAIDs, we have to be very safe in patients who have some other underlying renal dysfunction. So in such patients, we prefer Cetadone, which is basically very simple, paracetamol plus domperidone. So combination with caffeine is also something that is very helpful for these patients with migraines. Now, when it comes to moderate to severe migraines, so here ergot alkaloids or triptan. So ergot alkaloids have been historically recommended for migraine prophylaxis, but I personally do not recommend it. And even the most of the neurologists, most of the physicians do not use ergot alkaloids due to a lot of side effects that we encounter. Triptans would be the best here. So triptans are more effective than ergot alkaloids. So the triptans commonly that we use is sumatriptan, rizatriptan, and rizatriptan actually we get these sublingual strips, 5 mg strips, and they melt and give immediate relief. So that is something that in very excruciating headache you can give. So what I tend to do is if a patient has severe migraine, so what I do is I give Naxdom or Cetadome SOS for, and I explain to them this is for mild to moderate, and I also give them Rizanet or Rizatriptan and say that this is, when you have this excruciating headache which you're really not able to bear, only then use the triptan.
Dr. Vimala,
So, yes,
we have a question from the audience.
yes,
Dr.
ma'am.
Harsimran wants to know, is the presence of triggers suggestive of migraine?
Is the presence of triggers suggestive of migraine? So,
Harsimran, you can unmute yourself and ask your question.
Yeah. Hi, Dr. Vimla.
hi, ma'am.
Dr. Vimla, I just wanted to know, like, we have patients coming in the OPD, who would say, we feel hungry and then we start having headache, or, we go out in sun and then we start having headache. So is it a good enough factor that should point us towards the presence of migrainous headaches? Or should we
Yes,
have some other
now
deep in mind as
I
well?
understood the question. Yes, yes, yes. Actually, ma'am, that definitely is a supportive factor. So even we have patients who sometimes have a recent onset increase in intensity, and they don't give us the past history. So when we ask them, what about when traveling, what about if your food, if your food is late, as you mentioned, does that trigger a headache? And yes, we can use it as an indirect evidence of migraine, even though it is not mentioned in any of the diagnostic criteria. In general practice, yes, definitely we can use it as an indirect evidence to suggest that probably the patient has migraine. This is an important point, especially when we're trying to decide whether to image the patient, whether we are dealing with a primary headache disorder or a secondary headache disorder. So yes, you can use triggers as a surrogate marker to make a diagnosis of migraine.
Right. Dr.
I hope
Vimla, one more
that.
thing. So, like,
Yeah.
sorry. Yeah. So is the frequency of the headaches, should we take it into consideration when we refer the patient for a headache to the neuro? Like some people
Yes.
would say we have headache just
Yes.
once a month. So is it a good enough, frequency which should mandate referring to a neurologist, or should the frequency be more or something like that?
So the thing is, ma'am, we use frequency basically to decide what type of medications we give. Frequency of two or more per week, or causing an impairment in the lifestyle and functionality, means the patient has disabling migraine. What I would suggest is, rather than and then I will speak about the prophylactics that we will use down the line. So rather than using the frequency as a point of referral, once there is conclusive evidence diagnostically that it is migraine and there's no doubt about it, and you initiate, say, one prophylactic medication, and patient responds to it, you can continue the management therein. But if the patient does not respond to an initially prophylactic medication, then definitely the referral should be immediate. If the patient is having more than frequency, the intense characteristic of the headache, that patient is not able to function at all, and you feel one prophylactic may not help and patient may require a multimodal management, then the referral should be immediate. And if a patient has frequency of, say, less than around 1 to 2 per week, which is aborted by abortive medications management, there is no requirement as such for a referral at all. So I think the point here is that the diagnosis should be very certain. If there is any doubt in the diagnosis, could there be a secondary headache, the referral should be immediate. Otherwise, based on the frequency, if the frequency is low, obviously referral will not be required. And if there is excruciating or rather a severe intensity of migraine, then probably a referral has to be done earlier. I hope I was able to.
Yeah, that was very clear. Thank you so much, Dr. Vimla. Another doubt similar. I mean, if a patient says then, they have neck pain and, they have headache along with that. So does it point toward a cervicogenic for sure, or still we can consider it as a migraine?
Ma'am, there we'll have to see whether it is occurring in isolation only with radiation of pain from the neck above, or is there
Right.
migraine features as well. And sometimes there can be overlap between the two. Patient can have coexisting cervicogenic headache along with migraine headache as well.
Migraine is.
So, but if a patient doesn't have any of the features fitting our diagnostic criteria, and patient has only this kind of referred pain, then we think of more in terms of cervicogenic, and they can occur hand in hand also.
Right. Thank you so much, Dr. Vimla. Thank you so much.
Dr. Vimala,
Thanks.
Dr. Ravi has a
Yes.
question for you. After that, I have
Yes.
some
Yes.
questions for you. I think Dr. Ravi,
Yes,
you
ma'am. Please.
can take
Yes.
your
Okay.
question.
Sure,
Ma'am,
please.
you had mentioned that you start them with naproxen and domperidone and
Yes.
at the onset of the headache. Now, very
Yes.
often patients don't take it at the onset, and then you said if it doesn't work, then you ask them to take a triptan. So
Hmm.
my question was this: that like if the initial medication doesn't work, what is the frequency? How soon should they repeat the dose, or proceed to something else?
Yes, sir. More, if the medication starts to work, it starts to work within half an hour. And of course, the
Okay.
peak response will be there up till 2 hours. Within half an hour, if patient has no response, rather has worsening in intensity of headache, immediately it would be better to go to the second set of tablet. In this case, see, for example, if the patient has taken only 250 mg of naproxen, they can take one more tablet. If they've already
Mhm.
taken 500 mg, it would make logical sense to go ahead and take the rizatriptan next. So if half an hour at least reduction in intensity, increase in intensity, go ahead and take the second tablet, right?
Okay, and one more thing, ma'am, maybe you will be covering it later on in the talk, but we have patients with these very typical symptoms. But
Yes.
there would be some baseline investigation we would do. So I guess later on, once you've covered all the headaches, you would guide us, I suppose.
Yes, yes, sir. Yes, sir. I think I
Okay,
will.
thank you.
Yeah, Vimala. Uh, uh, I think you'll, the same way Sir said, you'll be covering about pregnancy and migraine too, because we would want to know the effect of pregnancy on migraine and the effect of migraine on pregnancy. Would you be able to address that, please?
Yeah, I have not covered that, ma'am, because my slides were quite extensive. But I will give a brief. Yes, because that's a very and a migraine and headache. I'm sorry, migraine in pregnancy is something very very difficult to deal with. So the problem is that most migraineurs in pregnancy during the first and last trimester do have an increase in intensity and frequency of the headaches, and in them again, unfortunately, all we can do is non-pharmacological maneuvers that I have outlined before. Paracetamol is something safe across all trimesters, and basically we try very much with our biofeedback and lifestyle changes and all that. No, none of our prophylactic medications are recommended and told to be safe in pregnancy person.
Some of these patients that we had, uh, patients who had migraine and they just
I'm sorry, and
continued.
I just one more important thing that I have mentioned it in one of my last slides, that even in a patient who has background history of migraine, when they become pregnant, even though there is a risk that the migraine can worsen, here a referral to a neurologist would be a must, because in pregnancy, due to the underlying prothrombotic state, they are prone for a lot of other secondary headache disorders. So I have made a slide on that. So where some red flag signs that we need to look in pregnant females that would warrant rapid referral. Yeah, I'm sorry, ma'am. You were saying
Yeah,
something
yeah.
else.
I think you answered the same thing that I was about to ask you. There are some antioxidants on these pharmacy reps keep promoting for migraine. So
Yes,
how?
I have mentioned that down. Yeah, actually, there have been some trials, and I will elaborate on them. But yes, riboflavin, magnesium, they have actually done a lot of randomized controlled trials, and they have found that it is patients do report reduction in frequency and reduction in magnitude of the migraine headaches. And personally also, I have noticed that a lot of my patients for whom I do start these supplements, this combination of riboflavin with magnesium with coenzyme Q, especially the refractory migraineurs, somehow do respond well. So I will mention the medication and the dosage. It is something very safe, and I think it is something that can always be a add-on therapy to the usual prophylactic armamentarium of migraine medication.
So could you tell a few features about ophthalmoplegic and retinal migraine? Because it's not very common that we see.
Yes. So, retinal migraines, now in retinal migraine, this is more of a retinal aura rather than retinal migraine. So, this would be formed under the classic migraine with aura, and this aura will be retinal aura. Ophthalmoplegic migraine is a mud. It is and it should always be a diagnosis of exclusion. We have seen patients who have ptosis, they have restriction of movements which completely resolve with time. But in all such patients, important things like PCOM aneurysm that can cause third nerve compression with dilated, which we can present with a dilated pupil, which can again, mimic our, we may think this is a part of the trigeminal autonomic cephalgia, but in them, these PCOM aneurysms, etc., do have to be ruled out. So I have slides down that show this as a differential diagnosis. So I will elaborate more on that then.
Yes, thanks, Vimala. I think we can continue now.
Okay. The American Association of Neurology and the American Headache Society, based on an evidence review done in 2015, gave level A, level B, level C, and level U levels of recommendation for acute migraine treatment. And so level A was what we've already spoke: acetaminophen, this our ergot alkaloids, NSAIDs, opioids, triptans, out of which I would strongly recommend acetaminophen, NSAIDs, triptans. Level B, I'm sorry, level B recommendation goes for chlorpromazine, droperidol, metoclopramide, especially when you have status migrainosus, which is basically acute severe headache that is lasting for more than 72 hours. There we have found that these IV medications do help. Another level 2B level of evidence is magnesium sulfate. Then level C level of evidence would be anti-epileptics like IV valproic acid, ergotamine, NSAIDs. Again, this would be under level C. And level U, of course, where it is not exactly determined whether it is of use or no, and that is something we don't need to know. So triptans, I think I have covered. Coming to the newer drugs, which is the drugs targeting basically this calcitonin gene related peptide. So basically these are basically the G punts, which are supposed to be CGRP receptor antagonists. So they are not very commonly used, but it is something that's coming up, and this is something that's very helpful, especially in this severe migraine, which is not responding to our first line medications. One more new drug is a 5-HT1F receptor agonist, which is lasmitidine, and this doesn't activate the other receptors which might have caused side effects. So the advantage again would be that it has no systemic side effect compared to the other ones, and studies have also shown that it inhibits plasma protein extravasation that is evoked by the stimulation of trigeminal ganglion, which I had mentioned before in the pathophysiology. So this is one very good drug theoretically. Practically speaking, I have not seen its use in Mangalore, and I'm not very sure about the availability, but this is something that I feel in the future will be quite helpful. Ketamine, again, not it's a drug with inconsistent results, which we don't commonly use. But just definitely the G punts and lasmitidine. These are two things that probably in the future are going to be something we more commonly use. Now, when it comes to prophylactic therapy, now certain points to consider when we are deciding on the prophylactic therapy is that there should be more than 3 moderate or severe headache days a month, and acute medications are not reliably effective, or more than 8 headache days a month, even when the acute medications are optimally effective, because of risk of medication overuse headache. And some patients with relatively infrequent attacks, according to patient preference, physician judgment, especially like in patients with hemiplegic migraine. So when we prescribe a prophylactic therapy, obviously we cannot explain 100% reduction, but what we define as a significant benefit if there is a reduction in migraine frequency or days with headache of 50% or more. And the decision of whether worthwhile benefit has occurred is something that needs to be individualized. And again, this also can be greatly enhanced by the use of a headache diary. And the primary effect is to reduce the frequency, with the secondary effect being reduction of the magnitude. And once we start and once we achieve the significant benefit, then the question arises is when do we stop it? So either patient has developed intolerable side effects, or if the patient has no benefit after 2 months of therapy at the target dose, because we'll have to build up and reach the target dose, then the prophylactic therapy may be stopped and probably another medication retried. But more often than not, after 1 month, most prophylactic medications do show a therapeutic response. And once, so this was, you're given the medication, either patient improves, patient doesn't improve. Patient doesn't improve, patient has side effects, we stop it immediately. We do, before declaring that a prophylactic medication has not worked, we give a trial for at least 2 months. Once we have achieved migraine control, then the question we have to answer is how long should we continue this migraine prophylaxis? Now, there are a lot of studies which say a lot of things. Usually in our practice, what we do is we go for 3 to 6 months. But sometimes there are cases where we have achieved this headache control with a lot of difficulty. And in such cases, what happens is that we don't want to stop the prophylactic drug in a hurry, because then if they go back to the headache frequency, it will be something very distressing for both the patient and the doctor. So in that case, an individualized decision should be taken to prolong it for maybe a year or even more. But in general, if your patient had maybe moderate level of migraine with significant benefit with your prophylactic agent, after 6 months, medications can be stopped. And now, when it comes to choosing a prophylactic drug, each prophylactic drug has its advantage, its disadvantage. Each clinician has something they are comfortable with. In general, what I feel and what is something generally followed is that choosing a drug based on coexisting comorbidity makes the most sense, so that your medication is not only helping reduction in headache frequency and magnitude, it is also dealing with the other comorbidity. And I will give an illustrative example of this as we move ahead. So level A recommendation is valproic acid, topiramate, beta blockers like metoprolol, propranolol, and for short-term provatriptan. Now, so now these are all level A. So how do we choose between these? Now, in a patient, migraine can coexist with epilepsy. Here, clearly, the drug of choice would be valproic acid. Again, disadvantage, we know valproic acid can cause some hormonal imbalances, precipitate PCOD, weight gain. If a patient is already obese, topiramate would be a great choice, because that would also help in weight reduction as well. If there is coexisting migraine features with IIH, again, topiramate, great drug. Topiramate, only thing that we have to advise the patient is that make sure they stay well hydrated, because in the absence of that, they can predispose to develop renal stones. Beta blockers. Now, many of our patients along with migraine also do have some anxiety, so they actually can, even either during the migraine attacks or if not also, can give history of palpitations, sweating, nervousness, especially in crowds. So in them, propranolol or a beta blocker would be great. If a patient already has coexisting hypertension, again propranolol would be great. So there, probably choosing a beta blocker would make more sense. Now, level B evidence are our antidepressants, which is amitriptyline, venlafaxine, and atenolol comes under level B. So, again, here choosing based on comorbidity, patient with coexistent depression and headache, choosing amitriptyline makes sense. And amitriptyline, actually, what the dose what we are giving is not the dose that our psychiatrists give, but even at a lower dose, which is effective for our migraine headache, it does have some help on the mood, which is why in case of coexisting comorbidities, choosing amitriptyline makes sense. So for example, if there is a patient with coexisting anxiety and depression, combination of propranolol with amitriptyline makes sense. Or a patient who's having sleep deprivation with headache, amitriptyline makes sense. Amitriptyline is level B for migraine, but it is level A for tension type headache, which is another type of primary headache disorder. Again, as ma'am mentioned, this magnesium, riboflavin, they are included in level B evidence. So this is something that always you can give as an add-on. In fact, if your patient has headache frequency that doesn't fit the criteria to initiate prophylactic medications also, you can always put them on a course of riboflavin for 1.5 months, and it may actually help with even reducing that isolated few episodes of headache. Level C is something I don't think we need to bother very much about. But a small mention about carbamazepine and oxcarbamazepine. Sometimes migraineurs can have coexisting trigeminal neuralgic or other facial neuralgic related headaches, related pains rather. And in them, carbamazepine, oxcarbamazepine has been proved to be a good drug. The point here that we need to remember is that especially in elderly, it can cause hyponatremia. Agranulocytosis is also a side effect. So it should be used with caution. And then level U, where there is conflicting or inadequate evidence, which includes gabapentin, other antidepressants, beta blockers, calcium channel blockers like verapamil. And verapamil later we will see in trigeminal cephalgias is a good drug, but probably not here. However, Again, one small mention regarding gabapentin. Now, as Madam mentioned about cervicogenic headache, so what happens is, especially patients who have coexisting cervicogenic headache with migraine, we have observed that a combination of gabapentin with amitriptyline is a great drug. It helps for both, and even though it is coming under a level U evidence, it is something that we would recommend, because unlike a very close congener of it, which is pregabalin, gabapentin has no habit forming nature. So it is a great drug when it comes to cervicogenic headache. Now, again, this is, I think, something I already discussed. Beta blockers, start low, titrate up. This holds good for all our prophylactic medications. Amitriptyline, this is, I already mentioned this. Flunarizine. Now, flunarizine, even though the American Headache Society and the American Association of Neurology do not recommend in the level A, B, C, and U, it is a very simple drug, very minimal side effects. It also helps with people who have very mild sleep deprivation, and it can be started at a very low dose of 5 mg and then gradually escalated. So especially in students, I have seen very good response to flunarizine based on the weight 5 mg or 10 mg. So even though it is not in the recommendation, I think in the arsenal, first of the drugs that should be tried should be flunarizine. So before I go to the complication, in summary, I think based on the comorbidities, choosing the drug makes sense. Choosing the lowest possible dose always is good, and more often than not, starting with a single drug makes sense rather than starting two drugs, unless you feel that the patient is in a lot of pain, lot of discomfort, and there are 2-3 comorbidities that you want to address. All migraine medications, unfortunately, can predispose a patient to weight gain. That is something we have to tell the patients. But if they control diet and do good exercises, it should not affect significantly, except for topiramate. So topiramate is something when already we have an obese patient, topiramate would definitely be the primary drug of choice. And since I mentioned about exercise in lifestyle, I forgot to mention one important thing, that aerobic exercises of half an hour, 5 days a week, is something that has also known to have significantly reduced migraine frequency and migraine magnitude also. So that is one thing that we have to mention to our patients. So then the latest research, which may not be very helpful in this particular scenario, is Botox. So our onabotulinum toxin is something that has been found to prevent, and this help especially in chronic migraine. So chronic migraine is wherein they have headache for more than 15 days a month, more than 3 months a year. And so in them, we try all these things. So here we come to our riboflavin and magnesium and all that. Again, my personal experience with this has been very good. It is a safe drug, and there are actual trials that have been done that has proven its efficacy. So usually what we get is this ribofem MQ or magrium. So this is a combination of all these three. That's riboflavin, magnesium, and coenzyme Q. So again, stressing on the migraine headache diary, which is really helpful always to consider whether what are the side effects, weight versus the benefits, and see how the patient responds to the prophylactic medications recommended. New drugs, now again, drugs that are working on the CGRP pathway. Again, this is something new, something that's still upcoming, not very frequently used in India, but again, among our headache specialists, that is our headache fellows, so the CGRP antibody, CGRP receptor antibodies also are being used. Neuromodulation is something that is being used for very severe chronic migraine, which has not responded to any of our initial prophylactic agents, which can be invasive or non-invasive. But among all this, transcutaneous vagus nerve stimulation is something very simple that have been tried out in migraines. But again, there is a lot of further studies that needs to be done. Now, red flags for a diagnosis of migraine: sudden onset after the age of 50, increased frequency, severity, and character, New onset headache in a patient with an underlying medication, underlying medical condition, and headache with concomitant systemic illness, focal neurological deficits, papilledema headache. Now, one thing is that, couple of things here. In a patient diagnosed with migraine, with typical features of migraine, whenever there's a change, a sudden change in character, a sudden change in nature of headache, we have to consider it as a red flag sign, because patients who have severe migraine in general do have bad episodes. So in a patient who had very well controlled migraine suddenly comes with an acute severe attack, we have to make sure that we are not missing out on any structural pathology. And secondary headaches, secondary to say an intracranial space occupying region, etc., can sometimes mimic a migraine headache in semiology. They can also have photophobia, they can also have phonophobia, they can also have associated nausea and vomiting. So again, if it is a new onset headache, it is a definite red flag sign. As I already told at the beginning of this one, that extremes of age, again, always a red flag sign. No harm in getting an imaging modality done. And a very brief mention about the type of imaging modality. Now, for example, patient has come to you and it's acute severe attack of migraine, and you feel you want to get an imaging done. Ideally, all the recommendations say across the board, MRI would be the ideal imaging modality of choice. We can visualize the brain, we can visualize all the nerves to a very a beautiful extent. Of course, if we do not have MRI available at that point of time, patient is in severe pain, CT is always an acceptable mode of investigation of choice. Now, in conclusion, migraine is something which is exceedingly common. It's something seen 1 in 4 women, 1 in 10 men. Even though we have multiple pathophysiologies that have been proposed, animal models, human models, it's still said that there is certain component that perhaps we have still not understood. Diagnosis, again, is primarily based on history. Treatment is abortive, which is specifically for the termination of the severe headache, and then preventive, which is to prevent the attacks of future episodes. Newer modalities of treatments, actually a lot of research is going on, but still it is inconsistent. Our garden variety medications are always the best, and of course there's a lot remaining to be understood regarding the migraine pathophysiology. So once we diagnose, we have to assess the disability, educate the patient, and then individualize the management for that patient, and then finally stratify the care. So one thing that has to be conveyed to the patient is that it's a disease, it's a lifelong ailment that they have to learn to live with, and our role is to make things as comfortable as possible. In general, what I personally feel is that it's better to over investigate rather than under investigate and miss out on any particular structural issue. So any red flag sign that you feel directly, it is better to go ahead for an imaging. And in fact, one of the main things that we use for a red flag sign for us neurologists, which is something that you all do, like the back of the hand, is fundus examination. So always we for our residents and everything, always say with headache patient, first thing we check is fundus. That is something that is very easy for you also. That is something that we should always remember. Now, shall I move on to the other type of primary headache disorders?
I have 3 questions for you.
Yeah, couple of questions.
Yeah, Madam, you can go on, please. Sapna ma'am.
Yeah. See, I think initially mentioned something about magnesium and role. So do you investigate for the levels of magnesium or electrolytes or any such thing, blood test or supplement extra?
I have, to be honest, till you pointed out, madam, I never thought of it. So, but one thing is that whatever supplementation is being given in these magnesium tablets, they are at a very subtherapeutic level. So there is no chance that even if the patient has normal levels of magnesium, we will be precipitating a toxicity of any cause. And dosage wise also, they are very subtherapeutic. So but unless we have a particular reason to suspect a dyselectrolytemia, no, we will not use, and we will not check for electrolytes. In fact, the things that we take precaution when starting prophylactic agents, for example, before starting propranolol, we do check a heart rate, we do get an ECG, we do look for PR interval. Before starting topiramate, we usually get clearance from ophthalmology whether we can go ahead, whether the IOP is normal. And if a patient with a predisposition, say an ethanolic, we're starting valproic acid, we do get liver functions done. Yeah, other than that, no, we don't do electrolyte levels per se.
Yeah. One more, there was somewhere I read about hyperbaric oxygen being used to break the episode of migraine or the treatment. Is it any role of
So,
that?
yes, so there have been a lot of studies trying to analyze oxygen in migraine, but they have not given any proven any very efficacious results. When it comes to headache and oxygen is what is abortive for cluster headaches. So that is something very, very clear cut. But in migraine, no. And in fact, the headache associated with some amount of trigeminal autonomic neuropathy symptoms terminating with the oxygen therapy goes more in favor of a diagnosis of a cluster headache.
Okay, okay. Thank you. That's nice.
And Dr. Harsimran wants to know what is the role of melatonin in treating.
Melatonin again would be under level U. Melatonin, it is a certain small studies have found that melatonin is useful, but there has been no conclusive proof across the board. However, if certain patients sleep, because the lack of a sound sleep can precipitate a migrainous attack in the morning. So in such patients, giving melatonin to stabilize the sleep cycle will make sense. And usually we start at 3 mg and see for a response. But directly correlation between melatonin and migraine has not been proven.
Dr. Anju wants to know what's the dose of Migranta.
Migranta, I am not aware of.
Okay, madam, can you tell us what it contains? Anju ma'am.
Good evening, ma'am. It is the
Good evening,
combination
good
what
evening.
you were talking about, riboflavin, the
Okay, the riboflavin, magnesium, and coenzyme
yeah,
Q.
yeah,
So that is magrium, ma'am. It's a fixed dose. It's a fixed dose combination. So there is no variable dosages in that. The only problem when we started is some patients can have GI side effects. So what we do is initially we give half a tablet, and then we make it full. But I am not very aware of the specific dosage, but it's a fixed dosage combination.
so it's a once a day preparation. Like
Once a day in the morning. Once a day in the morning.
Okay, and it has to be given for a month or something like
As
that.
part, if you're giving it as a migraine prophylactic, we give it for 2 to 3 months.
Okay, okay, ma'am. Thank you so much.
Thank you.
I think we can continue, Dr. Vimala.
Yes, yes. So coming to the second type of primary headache disorder, which is basically tension type headache. Now, in tension type headache, basically uh, the threshold for pain sensitivity is lowered, and there is a myofascial stimulation that happens here. So if you remember my first slide, classically we have a hemicranial headache, which is migraine, usually V1 distribution, which is trigeminal cephalgia, and tension type headache, which patients classically describe as a band-like feeling around the head. So the International Classification of Headache Disorders divides it into infrequent, frequent, chronic tension, probable type of tension headache. So when we say infrequent episodic type of tension headache, there can be at least 10 episodes of headache, less than 1 day per month, less than 12 days per year, each episode lasting 30 minutes to 7 days, which is bilateral in location, pressing or tightening in quality, mild or moderate in intensity, not aggravated by routine physical activity, and no nausea or vomiting, and no more than one of photophobia or phonophobia. Because if those things are present, obviously this will go in favor of migraine. And again, your location and character is something that is different from our classical migraine headache. Now, a further infrequent episodic headache has been classified with presence of pericranial tenderness and without pericranial tenderness. The same character of the headache, but if these 10 episodes are occurring 1 to 14 days per month for greater than 3 months, that is greater than 12 and less than 180 days per year, fulfilling the other characters, this is a frequent episodic tension type headache. And then this again with or without pericranial tenderness. Chronic tension type headache occurs for greater than 15 days per month, on an average greater than 3 months, so more than 180 days a year, and the other characteristics remain the same. Again, classification with or without pericranial tenderness. Now, here what happens is, because of this myofascial tenderness and this pericranial tenderness, it is usually secondary to this reduced pain threshold. And here our symptomatic treatment remains the same. The non-pharmacological prophylactic treatment remains the same. And in fact, here the prophylactic treatment is the non-pharmacological prophylactic treatment response is far superior to the one that we encounter in migraine headache. And here in prophylactic set of medications, it is completely different from migraine headache, where the first drug of choice is amitriptyline, the second drug of choice is mirtazapine, and the third drug of choice is venlafaxine. But most of our patients with tension type headache do respond very well with amitriptyline. So diagnosis wise, it's the location, it's the character, and more often than not, it is associated with pericranial tenderness. And treatment wise, ideally, it is amitriptyline is the way to go. So then coming to the next major topic, which I think and these patients I feel are more likely to come to you rather than to us, is our trigeminal autonomic cephalgias. Now, there have been a lot of shuffling in the nomenclature, and they had the SUNA, the SUNTA, and then it was put together and apart, and there are a lot of subtleties to differentiate between each type of trigeminal cephalgia. But one thing that we need to understand is there can often be an overlap. Patients with SUNA can have paroxysmal hemicrania also sometimes. So making a very strict definition and a clinical diagnosis can sometimes be difficult, but they are all characterized by activation of the trigeminal system. So the main three arms of underlying the pathophysiology of trigeminal autonomic cephalgia is basically the pain system. And this pain system is the trigeminal nerve, the trigeminal-vascular complex, and the general pain system, which is called the pain neuromatrix. Then it is the cranial autonomic system, and the cranial autonomic system includes, in this case, a superior salivatory nucleus and sphenopalatine ganglion and the hypothalamus. So it is a interlink between these three structures that leads to the clinical picture that we see. So now, to understand what are the manifestations, we should just understand how we make a diagnosis of each form of headache. So beginning with cluster headache. So cluster headache, to fit the definition, there should be at least 5 attacks wherein there is severe or very severe unilateral, orbital, supraorbital, and or temporal pain lasting from 15 to 180 minutes when left untreated, of course. And it should be associated with at least greater than one of the following, which is conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead and facial sweating, forehead and facial flushing, sensation of fullness in the ear, meiosis and or ptosis, and then a sense of restlessness or agitation. from 1 to 2 per day to 8 per day for more than half of the time, and of course not accounted by any other better ICDH diagnosis. So to say it's an episodic cluster headache, these clusters should last from 7 days to 1 year. The greater than 2 cluster periods lasting for 7 days to 1 year when untreated, but there should be a pain-free remission period of greater than 1 month. And if this remission period is not there, then we call it a chronic cluster headache. Then coming to paroxysmal hemicrania. So paroxysmal hemicrania and hemicrania continua are both at the same end, at the ends of the spectrum. So there in paroxysmal hemicrania, to understand, it is a short headache, while hemicrania continua is episodic headache against a background of chronic pain. So in paroxysmal hemicrania, there are at least 20 attacks, and these attacks, each attack is severe unilateral, again, orbital, supraorbital, temporal. The location remains the same as cluster, but the duration is much less. The duration here is 2 to 30 minutes. And here also greater than 1 ipsilateral, the symptoms remain the same. The frequency is greater than 5 per day for more than half the time, and prevented absolutely by therapeutic dose of indomethacin. This is something very, very important, and this is actually a part of the diagnostic criteria. So whenever you think patient has paroxysmal hemicrania, both paroxysmal hemicrania and hemicrania continua respond exceptionally well to indomethacin. So again, here it can be episodic or chronic. Now coming to short-lasting unilateral neuralgiform headaches. So here, to make this, it was 5, then it was 10. Here it is 20 attacks, and it can be moderate or severe, unilateral. Again, the location remains the same, and here the duration is much lesser. The duration is 1 to 600 seconds, which occurs as a single stab, series of stabs, or in a sawtooth pattern. I have put a, I'm sorry, I think this slide. This is just for us to understand what are the 4 types of patterns that we can see in this particular form of headache. So, again, the symptoms, the location all remain the same, but the duration is much lesser. The frequency is much, much higher. And here, they again recognize 2 subtypes. This was a new terminology, new subdivision by the 2013 classification. So this said either it is with both conjunctival injection and tearing. So that would be SO and SUNCT. And then if not, it is only with cranial autonomic symptoms with either conjunctival injection or tearing, which is SUNA. So again, here also we have a classification of episodic and chronic. Now, differentiating between the two is not very important, but I will show a table in the end where we can try to differentiate between each type. Now coming to hemicrania continua, here this is a unilateral headache. It is present for greater than 3 months with exacerbation of moderate or greater intensity. And it either has one of the two, point 1 or point 2. Point 1 being ipsilateral symptoms of trigeminal autonomic nervous system involvement, or point number 2 is a sense of restlessness, agitation, or aggravation of pain by movement. This is something very unique to hemicrania continua. It's also encountered in cluster headache, but it is something very, very unique and very, not unique, characteristic of hemicrania continua. Again, it responds absolutely to the therapeutic doses of indomethacin and not better accounted by other diagnoses. Here, they have classified into a remitting type and an unremitting type. And then probable TAC, which is something we don't need to differentiate. So when it comes to differentiating between these, entities, again, there can be an overlap between the two. But in general, the duration and the frequency go inversely. So when it comes to cluster headache, there is a male predisposition, while otherwise in hemicrania continua, there is a female predisposition. Otherwise, it's almost a 1-to-1 ratio. The type is the same, which is stabbing or throbbing, but in cluster, it's more often stabbing. Severity is severe in all. Site remains the same in all. Frequency, again, it is 1 every other day to 8 daily. But in here it comes to 5 to 40 daily, here 1 to 200 daily, and then of course continues with exacerbation. Autonomic features are seen in all. Restlessness and agitation again seen in all, but it is a characteristic feature of hemicrania continua. Migrainous features can be associated, especially in cluster headache, but it is not that commonly encountered in the others. Alcohol is a trigger for our cluster headache. Stress, exercise, alcohol also can be a trigger. Tactile stimulus is a very, very important trigger that is for both SUNCT and SUNA. And again, alcohol acts as a trigger for hemicrania continua as well. Endomethacin responsivity is seen only in the second and third one. Abortive treatment for cluster headache here, very importantly, oxygen is something very, very therapeutic. Triptans also work well. Abortive treatment for our SUNCT and SUNA is lidocaine infusions, but again, this is something not very commonly used. Prophylactic treatment, here comes the calcium channel blockers. So if for cluster headache, verapamil is an excellent drug. For hemicrania continua and paroxysmia hemicrania, indomethacin is a great drug. And when it comes to a SUNA SUNCTA, lamotrigine is an excellent drug across the board. It reduces the frequency, reduces the intensity to a very significant extent. And the second medication and third medication that are equally efficacious here are oxcarbamazepine and topiramate. But in general, what we prefer is lamotrigine. And here, lamotrigine, also one thing we have to be a little bit careful about is its allergy-related side effects. So it can cause rash, it can cause Steven Johnson-like syndrome in the initial phases. So always it has to be accompanied by a prescription mentioning the same. So this is a very silly thing to say, but just for our understanding, the shorter the name of the syndrome, the longer and the less frequent are the attacks of pain throughout the day. So cluster headache, paroxysmal hemicrania, SUNCTA, SUNA, and the prolonged name, and it is stabbing, shooting few seconds only, like that. So something to differentiate, one thing, mimic what we have to differentiate is one between trigeminal autonomic cephalgias and other primary headache syndromes. So this we have already very clearly differentiated, but when compared to migraine, we know migraine is variable, unilateral, location is different, duration is for hours of days. Autonomic features can be seen in migraine also, but they are much less frequent when it comes to in comparison to trigeminal autonomic cephalgias. And again, the triggers here are variable and what we have already discussed in detail. Trigeminal neuralgia. Now here, trigeminal neuralgia, usually the distribution is more often V2, V3. But when it comes to our trigeminal cephalgias, the distribution is more often V1. And of course, the character is also different. They describe a sharp shooting pain. The triggers here are cutaneous, thermal, mechanical. You must have seen most of our trigeminal neuralgia patients, they say when they brush their teeth and, gargle with warm cold water, they have that severe shooting pain. So this is something trigger which is specific to trigeminal neuralgias. And then primary stabbing headache is also a differential, but there are no autonomic features, and this is something that we usually will not get confused and confused with. So between SUNCT and SUNA, length and type of attacks are important to differentiate between the two. And I have already spoken of the pattern, that pattern of pain that is experienced in these cephalgias. So one important point is the presence of a cutaneous trigger, the lack of a refractory period between the attacks, and the prominence of cranial autonomic symptoms. This is something that we see in SUNCT, which is not seen in trigeminal neuralgia. And when it comes to cluster headache and the hemicranias, agitation is something that is very important to differentiate between the other two. One very, very important thing here is whenever there is SUNA and SUNCTA, pituitary pathology is something that has to be ruled out. So even though the patient may be fitting the classical textbook definition of a trigeminal cephalgia, more often than not, in all these patients, we go ahead and we do get an imaging done, because these secondary pathologies can occasionally mimic these type of headaches also. And as I had mentioned before, usually there is a syndromic overlap between these type of cephalgias. So if a patient say has overlapping features of maybe hemicrania continua and cluster headache, then probably we need to see what is the predominant type of nature of headache they have, and then decide to choose our prophylactic medication of choice. And if there are overlapping features of migraine, adding migraine prophylactics also will help. So whenever we deal with trigeminal autonomic cephalgias, these causes we have to think of and look for, especially cervical arterial dissection is something that we cannot afford to miss. So that is why in general, all trigeminal cephalgias, I do feel imaging is a modality of choice. Non-vascular causes, again, here, pituitary tumor is something that we have to commonly make sure we do not miss out on. So this was about trigeminal cephalgias. There is a lot of growing interest in this, and there's a lot of research going on to try to understand the precise pathophysiology and what is the exact treatment that will help such patients. But differentiating between the four types of headache can be clinically difficult acumen. So finding what is the predominant type of headache will probably help us address it better. Any questions at this point of time?
I haven't received any questions.
Okay. Okay, so then I will just move on to the other primary headache disorders. Now, these primary headache disorders are much rarer than what we have mentioned before. There's a cough headache, the exercise headache, but again, all these primary headache disorders are headache disorders of exclusion, and in all these cases, before a diagnosis is made, neuroimaging is a modality of choice. So here we divide them into short duration, long duration. See what is the characteristic trigger. Is it cough? Then it is primary cough. Is it exercise? Then it is primary exercise. What is the context? Is it cold stimulus, external pressure? External pressure, this is especially an occupational thing where they have prolonged instruments that they are wearing, that can cause external pressure headache. And irregular jabs and jolts, primary stabbing headache. But here again, as we differentiate to our trigeminal cephalgias, primary thunderclap headache. This is a very rare type of primary headache, wherein the intensity of the headache is achieved within a minute. And this type of thunderclap headache is again a diagnosis of exclusion, because lot of our secondary causes can lead to thunderclap syndrome. So unless we have ruled them out, it will not be included. So hypnic headache, new daily persistent headache, and nummular headache, again quite rare, and always diagnosis of exclusion. So coming to the final slide is just that what are the warning signs that should raise the suspicion of secondary cause of headache? And we use a very simple mnemonic, which is basically SNOOP. So in a patient who has systemic symptoms, so fever, night sweats, chills, you have to think of an underlying metastasis, infection. In our scenario, tuberculosis. I recently had a patient who had been suffering from headache since nearly 8 months, and unfortunately did have a lot of migrainous features, and then came to us with some new onset symptoms wherein he developed a cranial neuropathy, and we went down and diagnosed tuberculosis in him. So he did have history of loss of appetite, loss of weight. So again, systemic features here becomes very, very important. Any patient with an underlying C, even though they have migrainous features, here also secondary causes have to be ruled out. Clinically, presence of, this is very, very self-explanatory. Onset thunderclap, headache, always these are the causes: RCVS, SAH, CVT, dissection, apoplexy, and IH. These are the differential that we should always keep in mind, and that we should always rule out. Age more than 50 years, positional. And here, not just positional, whenever it is headache raised with associated with raised intracranial pressure, there is a characteristic increase of intensity of headache in the morning. So if a patient says to you that I'm getting up in the morning and I'm having intense headache, that should also act as a red flag sign to say that, okay, fine, I do need to get a neuroimaging done. Prior history, again, we have elaborated on this, which is new onset or change in nature of headache. Pregnancy, postpartum, new onset during pregnancy, always a red flag sign. And precipitated by Valsalva, again, this only could indicate that there is a raised intracranial pressure. So this is in pregnancy. So in pregnancy, this is something that we always need to make sure that we are not missing out, and what could be a clue of what the underlying etiology could be. So if it is orthostatic headache, it could be post-dural puncture. A thunderclap headache, RCVS, in the context of a postpartum lady, is something very, very important, basically where the major vessels go into a state of vasoconstriction, which eventually is reversible, but during the interim period can be quite lethal, and it can be episodic in nature also. So, relapsing thunderclap headache should tell us, should rule out RCVS as an underlying cause. Single thunderclap headache are the usual causes that we already discussed. Hypertension in pregnancy, there could be underlying preeclampsia, there could be underlying press. Again, very, very important. Presence of visual loss, preeclampsia, press, pituitary apoplexy, seizures, eclampsia, CVT, Horner syndrome, cervical artery dissection, papilledema, CVT, focal neurological deficits, of course, a stroke. So this in pregnancy with headache, we have to very systematically look for historically and clinically these findings. So I think I have covered the whatever is possible. I tried to do my best to give an overview, so I was not able to go into a detail of a lot of things, but yeah. So
I have two questions, Vimala.
yes,
Can you describe, in children, how common is migraine in children, and how
so
young
migraine.
a patient have you seen with
So the youngest patient that I have seen was a child of about 5 years of age who had migraine. So again, ma'am, the thing is, it is typical migraine, the same photophobia, phonophobia, everything. Sometimes children are not able to explain, so they do become a little dull, and sometimes they have associated cyclical vomiting syndromes, etc. Now one thing is that however, in children, we do keep a very low threshold to go ahead and ask an imaging, because again, extremes of age is a red flag sign. But here, family history is a very important diagnostic clue. So more often than not, most of the children who have come to me have had one of the parents who have had migraine. So I am more comfortable starting medications when one of them is affected. If neither parents are affected, and if it's a long standing short history, definitely an imaging of choice would make sense. And in children, this history taking sometimes becomes very, very difficult. So they say that I have headache since only 1 month. So then you ask, which standard in this third standard, second standard you have? Yes, I had. First standard you have? Yes, I had. So that is something that we need to be a little bit more cautious about. But clinical features wise, it is identical to our adult headaches, adult migraines.
Okay. Patients who present with occipital headache, we all think of
Yes.
hypertension first. So, is there any primary headache that can affect the that back region of the head?
Ma'am, there is no defined primary headache. So I have mentioned all the primary headaches here. But what we have seen is that this nummular headache and all is like a coin kind of a thing. So
Okay.
just occipital region, we don't have a defined headache unless it's an external pressure headache, wherein the patient is wearing a particular device, a particular helmet, and it's causing it like that. But what we have seen is sometimes there are a lot of occipital neuralgias
Yes.
wherein they have associated headache. So not necessarily always related to hypertension, but yes, in this patient, I'll be more cautious to make sure we're not missing a systemic issue out. But it is not a primary headache disorder.
Any other questions from the group? Dr. Harsimran has a question. Please unmute.
Yeah. So, ma'am, I just wanted to know, do you find any typical symptoms of, patients who are diagnosed with mass lesions? Do they have some particular kind of headaches?
Yes, ma'am. So, unfortunately, patients with mass lesions can have a very identical semiology to our migraine headaches. However, our migraine patients usually have resolution, at least partially, with analgesics, non-resolution with analgesics, protracted vomiting, projectile vomiting not associated with headache, severe photophobia that was never there before, and headache increasing in intensity in the morning once they wake up, headache awakening them from sleep, them waken intensity waking them up. So that is something that should indicate that maybe there is a raised ICP. Headache increasing with Valsalva manuals, coughing, sneezing, all that indicates a raised ICP. Clinically, of course, focal neurology deficit, papilledema, tandem ataxia, etc. But nature-wise, yes, these are the main ones.
Right. Thank you.
One more question. Do higher order aberrations cause or precipitate migraine? Rather, do refractive
I'm
errors,
sorry,
uncorrected refractive errors, higher order aberrations,
yes, yes, yes,
foliars?
yes, yes. They definitely do. They definitely do. And many of the migraineurs who have their refractory errors corrected do report a significant improvement in headache frequency. So definitely, most of the patients who come to our OPD, I do refer them for eye, and I do specifically ask for a history that in the class, are you able to see the board? Are you able to see this one? Because they do affect me.
Okay, I don't know the name of the person. iPhone it's written. Madam, can you just elaborate what do you mean by higher order aberrations in this? Is it post
Higher order aberration.
refractive surgery or something like that? Okay, let's see. If it comes up in the group, then I'll put it up to you, Vimala. Dr. Ravi has something to say. Yeah.
Yes. Ma'am, we see a lot of patients with comorbidities. For example, you know, diabetics, hypertensives, and then they come with these typical migraine features. So, what proportion? I mean, then we are wondering that is it, the hypertension going out of bounds? And very often they'll just be going to the practitioner who just, does their office checking of BP, says everything is okay. So that is something which concerns me, that what is the cardiovascular component? What is the, my other neuro component to the headache? If all the other
So,
imaging and everything is okay.
so if I've understood your question correctly, so in general, even though we do say that long unstanding hypertension does contribute a lot to headache, migraine features are something completely different. So
Okay.
hypertensive patients having headache usually occurs in the context of accelerated hypertension and hypertensive urgency and all that. But in a patient whose blood pressure is constantly on the higher side, them experiencing headache is less likely. So what happens is a patient where there is fluctuation in blood pressure, in them headache is much more common. In fact, I've seen patients quite comfortably sitting with 180, 170 BP with no headache because their body, their cerebral vasculature is used to that blood pressure, and they have actually the auto regulation is now set to that headache. So whenever there's a fluctuation in blood pressure is where they have precipitous headache. So
Right.
in case a patient with well-controlled blood pressure comes with headache, of course, it is irrespective. But if a patient with poorly controlled blood pressure is coming with a new onset headache, it is due to the recent lack of control. But unless there's a fluctuation, probably we cannot directly attribute the headache to the hypertension, and there may be a coexistent primary headache disorder also.
Okay. Thank you.
Thank you.
Uh, I am Dr. Arpana. I had asked about the aberrations.
Yes,
But it told I'm not to the post-classic or refractive surgery.
I'm sorry, ma'am, you're breaking up. I heard refractive surgery. I didn't wasn't able to. Hello, ma'am.
Hello. Yeah, I had.
Yes. Yeah.
Hello.
Yes, ma'am. I can hear you now.
Yeah, I'd asked about the higher order aberrations. If
Yes.
not in the context of post-refractive surgery, just like that, if one has higher order
Okay.
aberrations, can it cause
Yes.
migraine, and how do we treat it?
Ma'am, so basically refractory errors, isn't it?
No, not refractory errors. It is higher order aberrations on the corneal surface. We pick it up in the topography, corneal
Okay,
topography.
I am actually not aware if I'm not aware if there is a direct correlation between these aberrations and migraine, ma'am. But I will read up on it and get back to your group. I'm sorry, I'm not aware.
Okay, thank you. Thanks a lot.
Thank you.
I think there are no more questions that we can wind up. Call it today.
Yeah, it was a very elaborate and very nice.
Yeah, thank you, Vimala. You were really good.
Yeah.
Thank you, ma'am. It was really
Right,
excellent.
Yeah.
We
There was a
really
lot to cover.
appreciate
in
your
4
taking
minutes.
out the time and
Time
helping us.
exactly.
Yes,
Actually,
it's my
she was still in
pleasure.
the hospital when we were all sitting and chatting here. Thank you so much. I don't know if you have had your tea also.
I have been attending this as a patient as well as a doctor. So all the more important.